Welcome to Labcast, a podcast about the medical laboratory science profession, brought to you by MedLab Convo. To get notified once we drop an episode, you can do well to subscribe to all our social media platforms at MedLab Convo. For questions, feedbacks, and shoutouts, you can do well to send a mail to at medlabconvolabcast@gmail.com. Thank you for listening.
Imagine a small rural clinic where patients line up for hours under the sun. A child with malaria waits for a blood test, a pregnant woman needs her hemoglobin checked, and a man battling HIV requires monitoring. But inside the clinic, there's no laboratory scientist. There's just a nurse doing her best with rapid kits and handwritten notes. The reality: millions of people in underserved communities face this every day. Globally, there's a shortfall of approximately 10 to 11 million health workers by 2030, with underserved, rural, and low income areas bearing the brunt of it. That's the world of laboratory practice in underserved areas. It's a world where the absence of skilled laboratorians and equipment doesn't just mean inconvenience, it means delayed diagnosis, mismanagement of diseases, and in some cases, preventable death. Today on Labcast, we're asking, who shall I send? Who will rise to the challenge of delivering quality laboratory services where they are mostly needed? I am your host, Oluwadamilola, and here with me is my co-host, Jesutomisin. Hello, Tomisin.
Hello, guys.
So to help us explore this important topic, we are joined by MLS Francisca Ekwonu, a clinical laboratory scientist and an advocate for equitable healthcare access. MLS Francisca Ekwonu is a medical laboratory scientist with a strong background in healthcare service delivery and over a decade of experience working in the development sector. She holds a bachelor's degree in MLS and has been at the forefront of promoting access to quality healthcare in underserved communities. As a chief operating officer at the Center of Social Awareness, Advocacy, and Ethics, she has led initiatives that strengthen healthcare systems, empower young professionals, and support rural health interventions. Francisca is passionate about improving primary healthcare and ensuring that laboratory services, often overlooked in rural communities, receive the attention and resources they need to save lives. She has also received multiple recognitions, including the Effective Leader of the Year 2023 award and being named among the 50 Women of Impact for the year 2025. Beyond her professional work, she is a public speaker and youth advocate dedicated to advancing healthcare development and society in Africa. MLS Francisca Ekwonu, welcome to the show.
Thank you so much, Damilola. Hello, everyone. It's so good to be here on Labcast.
Thank you very much. So, without further ado, we'll go straight into the interview questions, and we believe that our audience are so excited to listen to you. So, right from the very beginning, when we say underserved areas, what does that really look like in terms of laboratory practice? And because you stated that you've had real experience with and the work you're doing with rural communities, what has been the biggest surprise about the practice of laboratory medicine in those areas that you've been to?
So, as a clinical laboratory scientist, I I believe that our role in healthcare is very instrumental. And this doesn't only play out in tertiary healthcare, it plays out also in secondary healthcare and in primary healthcare. Now we know that primary healthcare is the cadre of healthcare that is closest to the grassroots. So when you go to rural communities, right, you find primary healthcare centers. On paper, Nigeria has a minimum standard. It is called the National Minimum Standards for Primary Health Care that is developed by the National Primary Healthcare Development Agency. Now, this minimum standards requires that every primary healthcare center needs to have a functional laboratory for basic diagnostics. But really, in actuality, when you visit a lot of rural PHCs, you find out that these basic diagnostic services are absent. From 2021 to 2023, I led a project called the Local Government Good Governance Monitor Project. And in this project, I worked with 190 young people, so cutting across clinical scientists, health enthusiasts, investigative journalists, and people who are passionate, young people who are passionate about development. We visited over 300 primary health care centers across Nigeria, and we found out that not even up to 50% of them had basic diagnostic services present. You know, one of the biggest surprise for me was that patients were even being referred to chemists, chemists who didn't have any sort of medical licenses, right? Or they were being referred to like distant hospital, to secondary health care for issues that fall under primary health care. And it just shows that our minimum standards document isn't being enforced, isn't being put in place. So I think that's like one of my very big surprises, because I always wonder, like, so how is the officer in charge as the OIC at the primary healthcare center, or the doctor who is posted to that primary healthcare center, how are you able to make a diagnosis of what is actually wrong with someone if you are unable to get basic diagnostic tests done? Yeah, thank you.
Thank you very much for your response. And it's alarming how we think that healthcare in general can be managed without the presence of medical laboratory sciences. So then the question comes, how big is this gap? You've introduced us to a little bit about the documentation of primary healthcare center on paper and compared to how functional they are in real life. So are there any statistics on shortage of laboratory scientists and resources in rural areas or low income serving areas? Okay, no problem. So I emphasized on one of your major response from your first question, which was something about the data of primary health care center and the reality of how functional they are. So the question is, how big is this gap? Are there statistics on the shortage of laboratory sciences and resources in rural areas or low income areas?
Yeah, so the gap that actually exists in low income areas, underserved areas, or resource poor areas, the gap is actually significant. Nigeria's National Health Policy of 2016 actually highlights that human resource shortages, right, is one of the key barriers to universal health coverage, or the access to basic diagnostic services that we are lacking at the rural level or at the primary health care center level. And the projects that we carried out, our findings from that LGGM project actually reflected this. So we walked around the southeastern region of Nigeria, and our findings showed that over 60% of the PHCs, within the southeastern region lacked qualified laboratory professionals, as per what the minimum standard stipulated. Again, because laboratory professionals weren't going to be posted to a place where maybe there wasn't even a side lab, a basic side lab. For most of the facilities we went to, they were even struggling with having, standardized wards, delivery rooms. So many people often look at diagnostic services as just secondary, right? Or as sort of an ancillary service. They don't look at it as something that is required and basic. And it really talks, or it points to a more fundamental issue, which is the fact that in Nigeria here and in our rural communities, people self-diagnose themselves. People, if someone gets a headache now and says, "Oh, it's malaria," I mean, no test done, no proper symptom identification, and it's just automatically malaria. you know so even when we saw labs that existed, in the few facilities that we saw, they were managed by maybe personnel who didn't have like the requisite training, licensing, and certification to actually be operating laboratory services in that kind of setting. And then what they will mostly use are just rapid test kits. And we know that for some kind of diagnosis, you need to go like beyond just using rapid test kits. So yeah, this that contradicts the minimum standard documents, that is supposed to guide the performance of primary healthcare centers at the rural communities.
Thank you very much, Francisca, for your response. So, I'm glad we're talking to someone with experience, and we've identified that definitely there are barriers. So, from your experience, what are the biggest barriers that have limited laboratory operations in these regions? I mean, we've talked about the resources, human resource, and logistics, infrastructure, and otherwise. So, what do you think are the biggest barriers to having a fluent laboratory practice in these regions?
Okay, so the first thing I would say, the first barrier that affects, the proper practice of medical laboratory at the rural areas or at the underserved areas is infrastructure. So the minimum standards for primary health care actually designates how a primary health care center should be constructed. It tells the number of wards, the number of, even toilets. It goes down to the nitty-gritties of how a primary healthcare center should be structured. But you find out that most times there isn't space for labs. People who then eventually build these facilities, so the contractors, by some kind of reason, or because they are maybe trying to manage the very little space apportioned, or because they just don't deem it really significant, they don't create standout spaces in the facilities for these labs. Now, another issue is the fact that a lot of primary healthcare centers lack power supply. If you are a laboratory professional, a clinical laboratory professional, you would know that power supply is needed for almost every process, whether it is to run tests or to standardize tests or even to record results. You will need power supply to even maintain some of the reagents and test kits that require cold chain storage. You will require electricity, and that is lacking in many facilities. In some facilities where we even saw like solar powered maybe refrigerators that were provided by National Primary Healthcare Development Agency, or maybe the state government in some cases, or maybe donated by philanthropies, they're usually just used to store vaccines. You know, there are vaccines that are to be administered to children that must be maintained in cold chain. So you just find out that the solar is powering just that one refrigerator that is storing vaccines, and sometimes the food or the meals of the staff who are working in the primary healthcare center. So it's a lot of things going on there. There's no water. How can you run a laboratory without water? You can't run a clinical laboratory without water, because you need water even for the person working, to be able to wash their hands, maintain proper laboratory standards, and, follow the standard operating procedures for most of the tests that need to be carried out. Now, coming to human resources, because those areas are rural, And because the government itself, doesn't also play a lot of strong role as they should in incentivizing health workers to go down to the grassroots. This is not just happening with laboratory scientists, it's also happening with doctors and with nurses. Yeah. So there isn't sufficient incentives for clinical laboratory professionals to want to leave the urban settings to go to the rural settings. The national health policy also acknowledges that there's a maldistribution of health workers because rural areas don't attract laboratory scientists. So if there are no laboratory scientists, if there are no clinical laboratory professionals who are qualified with proper licenses, then there's nobody to run the tests at the grassroots. That is when the test will now fall into the hands of quacks or individuals who have simply watched the test being done. They don't understand the principles behind the test. For every laboratory test that you run, there's a principle behind it, whether it's in hematology, anatomical pathology, clinical chemistry, or microbiology. There's always a principle behind it. So that's what separates clinical scientists from any random individual out there. You have to understand the principle behind it. So because the qualified persons are not going to rural community because it's not attractive, you find out that there is a human resource shortage. Another issue is the logistics and supply chain coordination. So because test kits are very sensitive and laboratory reagents also have to be maintained within certain temperatures and transported in certain ways, they often don't reach the last mile because the grassroots don't have a properly planned logistics or supply chain mechanism that ensures that reagents get to those facilities, those primary healthcare centers. So because of that, some PhDs stay for long period of times. They don't get malaria test kits. They don't get other reagents that they need. Even as basic as running blood group typing. They don't have those things as basic as maybe identifying. Basic tests that should be able to identify issues or medical conditions of primary health concern. You don't have the facilities and the reagents to run it, so it's actually part of the challenges. And then another challenge is that the government is not remunerating, the government is not hiring. In most PHCs are under the control of the health secretary or the HOD of health in the local government. So, but because the funds of the local government has been for a long while now held by the state government, even though around August of last year, the Supreme Court passed a judgment and granted financial autonomy to the local government. But our experience is that yes, there is financial autonomy on paper, but the resources are mostly still being controlled by the state government. So it leaves the local government with little or no maybe resources to be able to employ more hands because the employee shortage or the human resource shortage in the rural communities is very great. And I really fear for the future of healthcare if the government doesn't sit up to start hiring more professionals. Thank you.
Wow, that's a lot to take in. But now that we've identified some of the barriers, I'm sure if I gave you an hour, you would speak again and again about a lot of things that are challenges to getting laboratory services in this environment. So, what strategies could the government and the non-governmental organizations use to incentivize laboratory scientists to work in rural areas? What strategies can be put in place?
Okay. So, Nigeria's tax shifting and tax sharing policy actually recognizes the need to redistribute skills where specialists are scarce, right? So, I think something our government can do would be to provide incentives. So if there are rural posting allowances, hazard pay, secure housing, for clinical laboratory professionals to work in the rural community, I believe that a lot of people would jump at it. I recall when I was doing my internship, and all the conversations around the hazard pay, are they going to pay hazard allowance and all of that? It was a lot. Some governments were not willing to, to pay that. Even when the federal government said, okay, they were going to pay, before the money got down to each of the health facilities, it was a lot of hassle. Some people never received the hazard allowance, and it was just a whole lot of things. The work that we do is very critical. The work that we do as clinical laboratory scientists is very unique. And there has to be room for no errors. Our error margins have to be very, very minimal. But how will somebody have a minimal health margin or error margin rather when they are running tests and samples if they don't have allowances that make them feel comfortable? Imagine having to go on machine bike, right? On a motorbike. You have to be on a motorbike for over like 40 minutes, 50 minutes, close to an hour, going to a facility, and maybe you're not even being provided with, transport allowance to help you get there. You'll find out that the professional will come on one day and skip maybe 4 times in a week. So the person might just come once in a week. And it may be the days when the person is not around that something goes wrong. A patient is in urgent need of medical attention and they need diagnosis, and the laboratory professional is not present because there are no incentives that's keeping the person there. Another thing the government can also do would be to ensure that people who are working in the rural communities, also have their experiences counting for them. So they're also getting promoted. The government can also put out scholarship programs that will incentivize people to say, okay, if you want to work in the rural communities, we have this education, and at the end of it, we post you to the rural community. So you know that you are working as a rural clinical laboratory professional to drive access to healthcare, and proper diagnosis, disease identification within the grassroots so that we can reduce the disease burden in the grassroots. Another thing is that professionals can be provided with health insurance and safe work environment. I've already spoken about it previously. So if all the stakeholders that are involved, in healthcare at the grassroots actually decide to sit up, they can provide a lot of incentives and support to laboratory professionals so that it would ensure that they are working in the rural communities and that we can help to drive access to universal health coverage.
Well said. Well said. So I can imagine a man who is a medical laboratory scientist, passionate about the community, but working in a rural environment where he doesn't even have secure accommodation. He doesn't know which school his kids are going to attend, or can't afford the school fees because the pay is so minimal. So if the
Yeah,
government can introduce these incentives, like, there are opportunities in the rural environment. If you're going there, you get free house. That is, your own. It's written in your name. Your
exactly.
kids can get
Mm-hmm.
scholarship at those schools, and stuff like that. I mean, many people would not mind leaving the hustle and bustle of Lagos to live in communities like that and still be able to feel fulfilled from their job.
Fulfilled.
So
Yeah.
it is very, very important. So I'd like to ask, can you share a story with us where the absence of proper laboratory services in a rural area impacted a patient's outcome or the health of a particular community?
Yeah. So during the LGGM project, when I was conducting the research across Nigeria, visiting primary healthcare centers, a PhD reported a maternal death, you know, and the woman died because of the lack of basic blood grouping and cross matching. if you are a clinical laboratory professional, you will know how important blood grouping is. Blood grouping can determine a lot of things. I mean, blood grouping can be responsible for a person's death like almost instantly, depending on which particular um blood group type you're talking about, right? So they reported that the woman had come in, and they couldn't perform cross matching. She needed blood and a lot of things. And because those services weren't present, they just decided to go with, what they thought could help. So they thought that the person who they were going to bleed, they had asked the person, so what's your blood type, and the person said O positive. It's very easy for people to say that their blood group is O positive. Oh my god. And they bled the patient and they administered the blood thinking it was O positive to the pregnant woman, and there was instant transfusion reaction because obviously that person's blood type wasn't O positive. That's O RHD positive, and because it's primary health care, they don't have the facilities it takes to be able to arrest that kind of situation. So before they could transport the woman to a secondary facility that has the um, equipment, that has all the provisions to be able to um, take charge of that situation and try to stabilize the patient, she died. So the woman and the baby died. So when people take blood grouping very lightly, the minimum standards documents for Nigeria, lists blood grouping as an essential primary healthcare service, primary healthcare center lab service. It is very essential and vital that we have proper grouping and cross matching kits at the primary healthcare center. So that woman just died with her baby after suffering for 9 months because of something as basic as blood grouping. It was a very gory story to hear. And I felt so pained as a woman myself because I know how stressful it is, for women to have to devote 9 months of their life to carrying a baby. And after all the stress, she lost her life and the baby also lost his or her life, you know. So, yeah, this is a very sad story. And the funny thing is that this happens even more often than we can imagine. A lot of people die simply because they cannot access basic laboratory services that is supposed to provide, you know, diagnosis of what specific condition is wrong with them. So yeah,
That's a very, very sad story. I mean, I don't know how I feel right now hearing this because, wow. And like you said, a lot of these things are happening more than we know or think because we do not even have access to those information. And we just hope that everyone listening to us right now who feels that they can do something about getting healthcare to these people would make the move. Policymakers, medical laboratory scientists like us, and even the government and every other person that really needs to do something about this will get to work. So, Francisca, I'd like to ask, just like we've been discussing these issues with rural communities and the likes, in environments where there isn't, so much of literacy, how do you communicate results to patients? Say for example you're in the northern environment and maybe an environment where they don't have access to good enough education to be able to understand, simple English and all. How does communication go on? how do you tell the patient, oh, you have this, or you have that, or this is what is wrong with you?
Okay, so when you have to relate with patients, communication is key. And communication isn't just when you open your mouth to speak. For you to say you have effectively communicated, the person whom you're speaking to has to be able to understand what you're saying. You know, they have to be able to hear what you're saying and understand it. If not, you haven't communicated. As clinical laboratory professionals, it is our responsibility to be able to communicate effectively, to other clinical staff that we work with, and then also to the patients. So the first thing you have to do is that if you're in a place where English is not maybe the first language, you have to be able to communicate in their indigenous language. So if you cannot communicate in the indigenous language, you will need an interpreter who can convey the message that you're passing to them in the most undiluted form, so that the quality of the message or severity of the message you're passing doesn't get watered down in translation. So while you run your tests and use standard values, standard metric reporting systems, standard units and all of that, you will not be able to tell a patient that your PCV, for instance, is XYZ. The patient doesn't know what PCV is. They will think you're even talking about voters card. The wonder if you made a mistake to refer to like Nigeria's PVC. They won't understand what you're talking about. So then you have to convey it in basic terms to say, okay, maybe your blood volume is low and this is why you feel weak. So you would need to do XYZ to be able to blood volume up and then be able to feel strong again. Also, you have to relate the results that you're giving to them to their everyday life, because whatever the result is saying, if the patient is anemic, for instance, you have to be able to explain to the patient what you suspect, right, might be the reason for that anemia, for that low blood. Once you say low blood, they understand. People mostly understand that if you have low blood, it may result in fainting, weakness, tiredness, and a lot of things. Those are the basic symptoms that they know and associate to with anemia, right? So you have to then be able to relate that result to their everyday life so that they can understand you. We also found out during the projects that we ran that using color codes was also helpful. So when you show something in green, most people see green to be that something is good. That means this is okay, this is proper, this is normal, the values are in normal range. Now, when we use red, it shows that, oh my God, these values are tanking, right? Your result is not in the normal range. Your result is risky. You need urgent intervention to be able to move this result, from this to that. So these are some of the ways that you have to be able to communicate to patients, who have like maybe limited literacy, whether it is by language barrier or even by health. We factor in all these things during health education, because as laboratory scientists, you also have to be part of the health education team, you know, alongside other health professionals at the primary healthcare center, to be able to teach and educate the patient. Because if you don't nip the root cause of the problem, so if someone keeps presenting with consistently low PCV values, then something is wrong. There must be a practice that they are doing that is making their blood volume to be consistently low, and that is very dangerous. Yeah. So helping them to adjust, teaching them, communicating in such a way that they can make lifestyle adjustments is one of the very good way that, helps patients understand their results and, you know, work to lead healthier lives in their day-to-day activities.
Quite interesting, I must say. I mean, this is such a wholesome task. As you're speaking, I could picture and imagine a case whereby a simple communication could have solved the whole problem.
Yeah,
In laboratory science, we know that error is not when you have done the job finish. It actually emanates from the start of the job,
yeah,
pre-analysis. And patient
pre-analysis. Yes.
communication is a huge factor. If the patient doesn't get the message on how to collect the sample properly, the essence of the test and everything like that, everything just goes down the drain. And they might, for
Exactly.
instance now, if you're to take fasting blood sugar and the patient didn't get the message that they ought not to eat before coming for the test, and it's supposed to be an early morning collection, there's going to be error in the analysis at the end of the day. So all of this is actually very, very important. It's a
Yeah,
wholesome task, I
it's
must say.
it it really is. Speaking about the fasting blood sugar you even mentioned, there's still a time limit, right? It's not just even about eating. There's still a time limit because if you overstarve the body, then the body goes back into the process of breaking down glycogen to get glucose. It goes into glycolysis. And so you may think that the patients themselves might think, oh, but I've been fasting since morning, it's 12 o'clock, you should still be able to take my blood sample to run fasting blood sugar. But you have to explain to them that no, I can't take your blood sample by 12. You've been fasting since the midnight. In fact, maybe they stopped eating, they ate their last meal by 8 p.m. the previous day, and this is 12 noon the next day. The body has already started breaking down glycogen stores to release glucose. So whatever result you're having is a false positive result. The blood glucose, the fasting blood glucose values will be elevated more than what it should be, and you will not get a proper result. So it's also very important that we communicate this to the patient. So maybe tell the patient that you have to make sure that you are in the PHC before 9 o'clock AM, so that you know that the body hasn't yet gone into starvation mode and then it's breaking down glycogen stores to release glucose.
Yeah, absolutely. I completely agree with you. You mentioned something striking about supply chain management and incentives the other time. And
Yes.
I know that you have a lot of experience and you must have come across a situation whereby you had to improvise due to lack of reagents and kits. You're forced to improvise. How did you navigate that path?
So, in all sincerity, improvising in laboratory practice, right, means you're compromising on accuracy. That's just it. It's like a case of where you're supposed to use maybe normal saline, you use distilled water, or where you're supposed to use distilled water, you use normal saline. These things have There's a reason why you're supposed to use normal saline and not distilled water. Because the composition of normal saline and distilled water are not exactly the same. So trying to, you know, trying to work with very limited resources is, in fact, I don't know. Personally, I don't like it as an individual because I like to ensure that my results are precise and accurate because that's one of the fundamentals, of putting out diagnostic results as a clinical laboratory professional. You have to make sure that your results are accurate and precise. So when you have to improvise, in all sincerity, it just forces you to make a presumptive treatment or diagnosis. Then you just have to try to work with the symptoms that you can see or that the patient is telling you, and then try to elicit signs. And in most cases, you may not be able to cover it through and through. Reason being that again, I mentioned self-diagnosis initially. Before a patient even comes to the hospital, or to the primary healthcare center rather, they already know what is wrong with them. Like, they believe that they know what is wrong with them. So they come and they tell you that they have malaria, you should do the test for malaria. So in those kind of cases, that we have poor resources, we're actually you just actually find out that you be contradicting the standards, the standard operating procedures that you have, for the different tests, and even the policy that we have as a country that says you should test before you treat. You just find out that you're giving treatment as, for lack of a better word, palliative measure, so that you will just ensure that the patient gets some relief. But the patient is getting some relief at the expense of proper treatment, or like focused treatment that is supposed to actually be attacking whatever is wrong with them. So I would really advise clinical laboratory professionals to, as much as possible, try to avoid situations where they have to improvise. I know it's not easy in resource poor settings, right? In rural Nigeria, it's very difficult. And so people just do all sorts of practices. Oh my God. People have some kind of factors that they use to multiply. And when you try to understand the principle of their factors, you just find out that it's some kind of made up factor, and or maybe somebody just looks at a sample and just says, "Oh, I think this blood sample is anemic, or I think this blood sample has this." It's just presumptive. It doesn't help the patient. It doesn't, because there's a reason why the test kits, the reagents, the diagnostic procedure is supposed to be followed to get the accurate result. So, hey, I'm just really going to say that let's try to avoid, the resource poor settings. I think sometimes it's better to even tell the patient that, oh, see, look at the situation of things, right? Than to try to give them hope or assurance that, this test, don't worry, we're going to do this test for you properly. And at the end of the day, you're just communicating diagnosis based on your knowledge of the symptoms, or based on how well you are able to, you know, say, okay, if these are the symptoms this person is having and you've elicited these signs, then this could be XYZ. But you don't have any definitive diagnosis to prove that. You just have a provisional diagnosis, and that will not help, that will not help. So we just really, really hope that our governments can, sit up to ensure that the basic resources that are needed for laboratory services to be effectively carried out in, rural communities can be provided.
Yeah, absolutely. I mean, absolutely. I love how you responded to that question. This sums it up to say that lack of laboratory infrastructure, reagents, kits, and all the necessary materials to work with, lack of all these things can weaken the system, can weaken the healthcare system, and
Yeah.
therefore
Mm.
water down the standard, which is
Yeah.
not what we want. So
At
yeah,
all.
yeah, a lot needs to be done from the government, provision and everything like that. So,
Yeah.
speaking about reagents and materials to work with, how can point of care devices, telelab services, or mobile labs help bridge the gap? And what are the limitations therein?
So I love the idea of mobile labs, and I've seen some organizations, both, for profit and non-profit organizations, put up mobile lab services. So the mobile lab services is coming up, as a response to a need that is existing, right? So people need diagnostic services to be able to diagnose diseases, and help them, get treatment, the best treatment regimen. So the clinician needs the diagnosis to be able to give the patient the best treatment regimen. But where it doesn't exist, so you now see um mobile labs coming in, so these point of care devices, the telelab services and the mobile labs, they actually align with Nigeria's health policy, where it pushes for innovation and technology in service delivery. you know Point of care tests, they can make diagnosis possible where labs do not actually exist. So say for instance the glucometer. With the glucometer you can get the fasting or the random blood sugar sample of a patient. Let's even assume that the patient is an emergency patient, is an emergency case, right? Maybe someone just slumped, or maybe there was an accident, or whatever it is, but the person came as an emergency. With the point of care testing device for blood sugar, which is glucometer, you find out that you get the results like almost instantaneously, as compared to when you have to draw the blood sample and then go to the lab and run the glucose test by the tube method, using the glucose standards and all the reagents. That takes like a longer time, and where you don't even have a standard lab, because again, where are you going to store glucose reagents? Glucose reagents cannot be stored on the counter. It has to also be in cold storage. So if there is no electricity, you don't even have a designated space within the primary healthcare center that is called the lab, you find out that you cannot actually run the standard glucose test that is supposed to be like more definitive than even the point of care testing. But when you don't have any other option, you then have to, employ point of care testing devices to help. But a very significant point must be noted, that these devices are limited, especially when it comes to sustainability. And the reason is because they need maintenance, they need to be calibrated regularly, and then they also need skilled clinical laboratory professionals that can use them, who understand the principle behind them. Because once you don't understand the principle behind any point of care testing kit or device, or you don't understand the principle behind any tests, you're just doing a mechanical work that you can't even explain. So if results fall out of the normal, you may not be able to pick it, or you may not be able to pick the reason why that result is not within the normal range. And it's not going to be healthy for the patient, because let me give an instance. So one of my friend was telling me how there was a time she was having constant headaches, and she didn't know her blood pressure was high. So she went to the hospital and asked for her blood pressure to be taken, and it was taken. And when the person measured it, the person actually saw her blood pressure up to 180. So it was like 180 over 100. And the person thought that the machine was malfunctioning. And the person repeated it a second time and found out again that it was as high as 182. But when the person was reporting it, they reported it as 120 over 80. Oh my God, that's a very sad thing. Now, because the person who was handling that sphygmomanometer, the electronic sphygmomanometer, did not understand the principle behind blood pressure, that the patient was complaining of headaches, constant headaches, and the person was seeing a really high result. Should have been a something to flag instantly. That patient should never have been allowed to walk out of that facility. The patient was supposed to have been placed on bed rest instantly, and then help to bring down the blood pressure, because the blood pressure was like too high at that time. But the person, because they didn't understand the principle behind blood pressure measurement, thought that the blood pressure always had to be reported as 120 over 80. it really took the grace of God of a more experienced person to see a more experienced healthcare professional, a nurse actually, to see that lady and say, wait, come, you don't look okay. Is something wrong? Have you had any form of rest? And then sat the lady down before she took the test by herself, and she found out that her BP was unreasonably high. And so she had to ask that the lady be admitted instantly. If not, they were going to lose her at any point in time. So it's really, really crucial that these point of care testing devices, although they come in handy in the mobile labs, they come in handy when standard laboratories that are needed in the primary healthcare centers are not available. It is important that they are properly maintained, they are stored in the proper way they are supposed to be stored. So some of these devices, you can't even store them in rooms that the temperature exceeds a certain degree, because where they were manufactured maybe in the temperate areas. But we live in the tropics, and because it gets hotter than what it is in the temperate, so some of these machines cannot work optimally, in very tropical areas. So there are parts of Nigeria that are really hot. If you take those devices there, you may get, varied results. And then you have to continually calibrate them and train the skilled clinical laboratory professionals, to be able to utilize these devices.
In all, everything matters: the professional, the expertise, and what technique that is being used, the reagent, everything just is like a web of science, and they all
Exactly.
matter. Yeah. So someone somewhere is probably faced with or at a T junction of, who shall I send? You have led initiatives that strengthen healthcare systems and also receive multiple recognitions. What's your message to aspiring laboratory professionals, policymakers, and global health leaders about stepping into this vital role?
My message is very simple. The clinical laboratory is not optional, it is foundational. Medical laboratory science is the bedrock of modern medicine. If we are going to be able to strengthen healthcare systems, laboratory science sits at the center of that, because without proper diagnosis, there cannot be proper treatment. So, to every aspiring laboratory professional who is listening to me, your role as a medical laboratory scientist, as a clinical laboratory scientist, is the difference between guesswork and proper care. You are that significant in the system that without you, the rest of the clinicians are just guessing. And that can cost the patient's life. And with you, the patients have a shot at proper care. So the policymakers in Nigeria's minimum primary healthcare center standards already say that every facility should have a lab. Now is the time to enforce it. Policymakers need to ensure that labs are created in the primary healthcare centers. As PhDs are being adopted for innovation and all, let the policymakers include and activate that part of the minimum standards that allows laboratories to be created in the primary healthcare center, so we can reduce the incidence of death, the prevalence of some of the diseases that are occurring in the primary healthcare areas or in rural areas because there's no proper diagnosis. And then, to every global health leader listening to me, if you want universal health coverage, by the Sustainable Development Goals, SDG 3, we are pushing for good health and well-being, universal health coverage by 2030. If we want to achieve universal health coverage where every individual is able to access quality health care at the right time, at the right place, for the right amount of resource needed to access it, and just to ensure that everybody has access, you can pay for healthcare, you can access the healthcare, when you need it, at the time that it is required to save someone's life, then global health leaders must invest in rural diagnostics. Because without laboratories, without clinical laboratories, without medical laboratories, communities remain invisible in the health system. Nobody will know that these are the issues that communities have. But when there are laboratories to be able to provide diagnostics, that is how you will know if there is a new species of a particular organism in circulation. So there has been conversations in Nigeria about a lot of people coming down with malaria. All over social media, people are saying that a lot of people are coming down with malaria now, and the malaria is killing people. So someone was saying that he has lost like 3 friends in the space of 3 months to malaria. And this malaria just starts out again, they call it malaria, but nobody knows if it's actually malaria because people haven't even tested to find out it's malaria. But there's also another conversation coming up to say that it's a different species of the falciparum malaria, right? It's a different species of plasmodium being carried by the female Anopheles mosquito. Now, this did not just wake up one day and start. It must have started from some community. Imagine if there was a medical laboratory scientist who was qualified, who was looking under the microscope at the blood film of a patient who had presented with malaria symptoms. And they were looking at it and they were seeing that, but wait, this is looking different from the regular falciparum malaria that we know. What is happening? You see that they would have raised a flag in the surveillance systems for malaria, and the NCDC would have even been alerted. So they would have escalated from, that facility maybe to the ward level, to the local government health HOD, down to the state, and then they'll be inviting the NCDC to come and witness the fact that there's a new species of plasmodium happening or moving around in communities, and it would have been able to be curtailed. But if what we are hearing right now is true, that there's a new species of plasmodium that is killing people, then it means that all hands need to be on deck, to actually ensure that we activate and provide quality laboratory services at the grassroots, at the resource poor areas, at the rural and underserved communities. Thank you.
Absolutely fantastic submission. And I can feel the passion with the way you talk. Absolutely fantastic. So we are at the section of this or that. So you have to select just one option. So are you
Okay.
ready?
Okay. Let's do this.
All right. Rural or urban practice?
Rural practice. I love community development.
Okay. That says a lot about you. I mean, so I don't even need to dig deep into why and what. Okay, right. That's beautiful. Okay, that is it for today's episode of Labcast. Thank you for sharing your insight and stories, MLS Francisca. It's clear that medical laboratory practice in underserved areas isn't just about tests and equipment. It's about lives, communities, and justice in healthcare. And the question remains, who will step into these underserved places where the need is greatest, And it could be you listening right now, the next scientist, policymaker, or innovator who ensures that no community is left behind. Don't forget to share and subscribe and let us know your thoughts. For sponsorships and collaborations, drop us an email at medlabconvolabcast@gmail.com or connect with us on all our social media platforms at medlabconvo. Remember, behind every lab result, there is a team making tough decisions to save lives. Until next time, bye bye.